So on that note, good evening, everybody, and welcome. Thank you very much for the opportunity to speak to you today. Thanks to Dr. Belmorris for the kind introduction and to Dr. Villanueva for putting the problem into context so nicely and so clearly and highlighting the importance of all of us working to address the burden of diabetic kidney disease. Now, I just need to share my screen, which is, needs to be enabled, please, so that I can put on my slides. And I'm going to take the opportunity today to share with you both a recap and summary of the Credence data, looking at the effects of canagliflozin in diabetic kidney disease. And I will also spend some time looking at some of the new data that we've generated from the Credence trial, which I think generates additional insights that hopefully you'll find important and valuable. I'm just going to need some technical help here because Zoom's saying that the host has disabled participant screen sharing, so I can't share my slides at the moment. Hopefully we'll get that sorted out momentarily. Here we go. Thank you for that. And hopefully you can see the slides there now. So I was the principal investigator of the Credence trial, and the Credence trial was funded by Janssen, and Janssen, of course, are supporting this meeting tonight. I'm very grateful for that. My only disappointment is I can't be there with you in the beautiful Philippines in person, but perhaps we can save that pleasure for another day. We've already seen this data from Dr. Villanueva that highlights both the existing burden, estimated to increase to 3.78, and in another decade, likely to increase to over 5 million, and with the largest growth in Asia, highlighting just how important it is that we find better ways to prevent kidney failure. And we've heard about the central role that diabetes has in that treatment paradigm. To date, we've only really had a single proven treatment that clearly prevents kidney failure in type 2 diabetes. And that, of course, is Renin-Angiotensin system blockade, and in type 2 diabetes, most clearly demonstrated with angiotensin receptor blockers. On the left, we have the Renal study results with losartan compared to placebo, and on the right, the IDNT study comparing irbesartan to placebo, but also comparing it to amlodipine as an active blood pressure lowering agent. And in both cases, we see reductions in the risk of the composite primary outcome of 15 to 20%. And I'll ask you to remember that magnitude, that 15 to 20% difference. Clearly statistically significant, which represents a significant advance. And also, it's clear that irbesartan was superior to amlodipine in the IDNT study. So this wasn't a blood pressure lowering effect. This was a specific renoprotective effect of this class of agents, likely due to their effects on reducing intraglomerular pressure. So a major advance almost 20 years ago now, and has been the cornerstone of the management of diabetic kidney disease to prevent end-stage kidney disease and the need for dialysis. But it's important to note also on both of these figures that if we look at the placebo arm, if we look at the actively treated arm with losartan or irbesartan, and we look out towards the end of the study at about 4 years, about half of the people, even with losartan and similarly with irbesartan, still develop death. So whilst we were able to push the curves a little bit to the right, clearly there's a substantial unmet need, suggesting we need additional treatments that can provide further renal protection. RAS blockade is not enough. On this background, I had the privilege of being involved in the Canvas trial program, and that study was started in 2008, and in 2012 there was an interim analysis that was planned to generate the data that would lead to regulatory approvals of canagliflozin. And indeed, the drug was approved at that time and became available in 2012, some 8 years ago. And while we were looking at that data, we noted this data. This was in participants in Canvas who were macroalbuminuric at entry, and it shows the change in proteinuria in the placebo arm, in the green, and in canagliflozin 100 and 300 milligram in the different shades of blue at the bottom. And what we see is a very clear and very substantial immediate and sustained reduction in albuminuria in those patients who had macroalbuminuria to start with. This was much greater than would be expected by virtue of the glucose-lowering effect of these agents, and it suggested that they might have a specific renoprotective effect. And this was 2012, long before we had any data on hard renal outcomes from any of the randomized trials. As a result of that data, we partnered with Janssen as a steering committee, and we designed the Credence Trial to specifically test whether canagliflozin might protect the kidney in the context of both the reduction of proteinuria and also an acute reduction in EGFR that was consistent with that was seen with RAS blockers, but also suggested that there may be a reduction in intraglomerular pressure that may lead to additional renal benefit. So we designed the trial in 2013. We began enrolling patients in January 2014. And of course, in late 2015, EMPA-REG reported findings demonstrating not only cardiovascular benefits, but suggesting in post hoc analyses of non-pre-specified endpoints that there may be substantial effects on the kidney. In late 2017, the Canvas trial reported, and then in 2018, we undertook a pre-specified interim analysis of the Credence trial, where the Independent Data Monitoring Committee recommended that the study be stopped early because there was clear evidence of benefit. And we reported the study a little over a year ago now, and subsequently we've also seen the results of the DECLARE trial, and most recently the Virtus CV trial of ertugliflozin report. Since we started the trial, there have been a number of hypotheses raised about the potential mechanisms by which SGLT2 inhibitors may have an effect on the kidney, as well as the effects on glucose, blood pressure, volume, sodium, etc. There are a whole range of effects on a number of different pathways that have been identified, but it does appear likely that a reduction in intraglomerular pressure, possibly driven by changes in tubuloglomerular feedback, and possibly also associated with other mechanisms of benefit, may be important. But to disentangle the mechanism by which SGLT2 inhibitors might protect the kidney. So we designed Credence in 2013, and we designed it not as a glucose-lowering trial. This was a trial undertaken specifically to test whether canagliflozin was protective for the kidney in people at high risk of kidney failure. It was the first efficacy trial of any SGLT2 inhibitor to be reported. All the previous trials had been primarily safety studies with secondary efficacy outcomes. And in addition, here we identified people as being at high renal risk, primarily by the presence of macroalbuminuria above 300 milligrams per gram. And we included people with a range of EGFR levels of between 30 and 90 mils per minute at entry. The HbA1c criteria were deliberately broad. People could be included down to an A1c of 6.5%. We were not seeking to understand whether the drug lowered glucose. We already knew that. And we wanted to see whether the effects were present on the top of the best available therapy at the time, which of course was either an ACE inhibitor or an angiotensin receptor blocker. So we required all participants to be on the maximum tolerated all-label dose of these agents for at least a month before entry. I won't go through the exclusion criteria, they're listed on the slide, but the trial design was pretty simple. After a 2-week run-in, we randomized people to canagliflozin 100 milligrams or placebo and followed them on a regular basis for an average of 2.6 years. People with or without cardiovascular disease were eligible to participate, and an important novel aspect of this trial design compared to the previous trials was that we did not stop the drug if people's EGFR fell below the established thresholds, as well as enrolling people down to an EGFR of 30, and as I'll show you later, in some cases beyond, people could continue in the study even if the EGFR fell below 30 during the trial, and were only required to discontinue if they needed to start chronic dialysis or had a kidney transplant. These are the primary results that we published in the New England Journal of Medicine last year and reported at the World Congress of Nephrology. We found a 30% reduction in the risk of the primary outcome, end-stage kidney disease, doubling of serum creatinine or renal or cardiovascular death with canagliflozin compared to placebo, highly statistically significant and very clinically important for our patients with diabetic kidney disease. When we look at the components of that primary outcome shown in this forest plot, whether we look at doubling of creatinine, end-stage kidney disease, low eGFR, or indeed dialysis or transplantation as the hardest of the renal endpoints, we see a very consistent pattern and clear evidence of benefit for all of those outcomes with canagliflozin compared to placebo. And if we combine those outcomes in different ways, as shown on the bottom, again, we see clear evidence of benefit with canagliflozin. What about the effects on kidney function? So this compares the rate of change over time from entry into the study of participants randomized to either canagliflozin or placebo. You'll see at the top that the average eGFR level at entry was 56 for both groups. And what we saw in the first 3 weeks was exactly what we expected to see, an acute reduction in eGFR with canagliflozin, likely reflecting reduced intraglomerular perfusion of about 3 mils per minute above that was seen in placebo. But subsequently, we see a progressive loss of kidney function of 4.6 mils per minute per year in the placebo arm, but we see attenuation of this rate of loss of kidney function to 1.85 mils per minute per year, a 60% reduction in the rate of loss of kidney function with canagliflozin compared to placebo. This may not sound like a much, 1.85 compared to 4.59, but you need to remember that the average follow-up duration in Credence was 2.6 years, clearly a much shorter time frame than the time frames that our patients with diabetes and kidney disease have to live with their condition for. So we did an exploratory analysis to say, well, instead of looking at of 2 or 3 decades of follow-up, and if we looked at the effects on kidney function for the average Credence participant who at entry was aged 63 years on average and had an average eGFR of 56, and if we asked the question, how long would it take them to get to an eGFR below 10 mils per minute per year per 1.73 meters squared, at which point they would be looking to prepare for dialysis and probably need to start very soon. And if we do the calculation starting at 56 and with a rate of 4.6 mils per minute per year, you can do the sums in your head. It would take the average placebo patient about 10 years to reach end-stage kidney disease if the rate of loss of kidney function continued at that same rate. So that patient would, on average, now be 73 years old and would be looking at long-term dialysis or canagliflozin arm of the Credence study. The loss of kidney function was 1.85 mils per minute per year. And if that protective effect was sustained, and we don't know that for certain, but it seems reasonable to assume it's likely to be comparable, what we can see is that the calculations suggest that that patient wouldn't get to an eGFR below 10 and be looking at dialysis until they were aged, on average, 88 years, some 25 years after starting. In other words, we potentially could delay the average timing of starting dialysis by 15 years for the average patient, longer for people with a higher eGFR at the time that the drug started, and for a shorter period of time, but still an important period of time in people who start with lower levels of kidney function to begin with. So this is an interesting sort of a mathematical exercise. It's not terribly scientific, to be clear, but it does indicate the sort of benefits that might be able to be obtained at an individual level by changes in the rate of loss of kidney function of the sort that were observed in the Credence trial. What about that acute effect? What does that mean? Should we be worrying about it? We recently reported some data on this question, and what we did was we broke the Credence participants into those who had an acute eGFR decrease of 10% or more, those people whose eGFR decrease was between 0 and 10% in the first 3 weeks, and those whose eGFR increased acutely. And we looked at that in both the canagliflozin and the placebo arm. And the key message here is, regardless of the magnitude or presence or absence of that acute reduction in eGFR, the long-term rate of change in the placebo arm was consistent at about 4.5 mils per minute per year, and it was dramatically reduced in all of those groups treated with canagliflozin to about 2 mils per minute per year. So having an acute reduction in eGFR was associated with consistent protection of the kidney in the long term. And this was true whether we looked at a threshold of 10% as shown here, or in a sensitivity analysis where we used a threshold of 20%. There were very, very few people who had an acute reduction in eGFR of 30% or more. And indeed, there was too few for us to analyse properly. But that also tells us that that sort of effect is really quite uncommon in people treated with SGLT2 inhibitors acutely. What about the cardiovascular effects? So this is the effects of canagliflozin in the Credence trial on major cardiovascular events, CV, death, MI, or stroke, standard MACE outcome. And we see again a highly statistically significant 20% reduction in the risk of this outcome. And importantly, Credence was the first trial to show a clear beneficial effect even in people who did not have established cardiovascular disease, the so-called primary prevention population, shown on the left there, where there was a very clear, separately statistically significant reduction in the risk of MACE with canagliflozin. So in people with kidney disease, it doesn't matter whether you've got cardiovascular disease or not, you get the same benefits from canagliflozin. We also saw significant reductions in the risk of cardiovascular death or hospitalization for heart failure as a composite outcome, a 31% reduction. And when we look at the other cardiovascular outcomes, we see that the components of MACE were reduced to a consistent level across each of them. And we see a very large effect on hospitalized heart failure, a 39% reduction, but there was no separately significant reduction in CV death or all-cause mortality where the confidence intervals just crossed unity. So the heart failure effects are a very big deal in people with kidney disease and probably have been underappreciated. So we've done some additional analyses to try and understand what are the mechanisms by which canagliflozin might protect against heart failure in people with type 2 diabetes. And we presented this at the American Diabetes Association meeting just a few weeks ago. And the way we do this is we look at intermediate markers that canagliflozin has an impact on. And then we look at whether those markers are related to the outcome of interest, in this case, heart failure. And we try and estimate what the percentage mediation is for each of these various parameters. And it's a long and complicated story, but to summarize, the results are shown here. So for heart failure, the data suggests that the acute effect on hemoglobin, or the long-term effect on hemoglobin might explain 30% of the outcome of the benefit on heart failure. So this suggests the possibility of a volume-related benefit, which is not surprising, but there's increasing data suggesting also that SGLT2 inhibitors might have an effect on erythropoietin production. So this is an area of ongoing study. The proteinuria effect was responsible for another 30%, so up to 60% for those two outcomes. When we add systolic blood pressure, it goes up to 66%, and uric acid to 73%. What this analysis cannot tell us is whether these mediation effects are truly causative, but it does suggest areas of important study that might help us better understand the effects of SGLT2 inhibitors. I think we reported at the American Diabetes Association meeting is also the effect not just on the first heart failure events, which is what we'd pre-specified, like most trials, as our primary analysis of this outcome, but we also asked the question of what happens if we look at all heart failure events and not just the first one. And you can see here that in the solid lines, when we look at total events, the number of events increases substantially, but we see almost identical reductions in the frequency of total heart failure events as we saw for individual heart failure events. So suggestive of ongoing protective effects associated with canagliflozin for this outcome. The other important thing is to come back to that point that I made earlier about the importance of heart failure in our population with diabetic kidney disease. These data on this slide are the proportion of people who had a heart failure event in the various SGLT2 inhibitor trials. And on the right-hand side there, across the three main cardiovascular outcome trials that were relatively consistent, about 8.5 in Canvas and Declare, but were entirely a secondary prevention population. Were similar in DAPA-HF, which was a population who had existing heart failure, in the Credence Trial in people with diabetic kidney disease. People with diabetic kidney disease have a higher risk of heart failure than people who are already known to have heart failure. So the effects of this treatment on this outcome are also extremely important. What about safety? Well, in the Credence Trial, we found that the risk of adverse events and renal adverse events was reduced. There was no increase in hyperkalemia or acute kidney injury. And indeed, when we pulled the trials, there's a suggestion that SGLT2 inhibitors, rather surprisingly, might reduce the risk of acute kidney injury. We've also done some additional analysis to say what happens to the people who had acute kidney injury in the canagliflozin compared to the placebo arm. And that data is here on the left-hand side, partial or no recovery. And you can see that people with canagliflozin, when treated with canagliflozin, were not only less likely to develop acute kidney injury, but if they did, they were more likely to recover fully and less likely to have no recovery. So there's certainly something going on, I think, with the effects of canagliflozin and other SGLT2 inhibitors on acute kidney injury. In addition, treated with canagliflozin who had acute kidney injury were less likely to end up on dialysis and also had lower rates of death, highlighting the potential value in this population. The other key outcomes we were interested in based on previous data was whether there was an effect on the risk of fracture, and the answer was that there was none. Pretty much identical rates of fracture in the canagliflozin and placebo arm, and also amputation had been flagged in the Canvas study as a potential concern, but here there was clearly no risk and in addition, we had implemented a protocol amendment when the Canvas results became available, but when we went back and looked at it, we could find no evidence that that actually had any impact on the risk for lower extremity amputation. So I think it's increasingly looking like that Canvas data may have been a chance finding. Just a couple of additional questions we've subsequently asked and we've commonly been asked is, are these benefits glucose related? Is this just a glucose lowering effect that we're seeing on the renal and perhaps the cardiovascular outcomes? And there's a number of ways we can address that. We didn't include non-diabetic patients, so we can't answer that from that perspective, but it is interesting to note the clear benefits for SGLT2 inhibitors on heart failure in non-diabetic patients with existing heart failure demonstrated in the DAPA-HF study. One way we tried to look at this in Credence was to look at the participants according to their HbA1c at entry. And we specifically focused on those who had an A1C below 7%. The average in those populations was 6.6%. And they had a very minor reduction in A1C, 0.18% overall. And in those people at A1Cs of 7 to 8% or above 8%, we can see larger A1C reductions as we would expect with this class of agents. But when we look at the effects on the primary outcome at the top or the other renal composites, reports later this year, as it included a proportion of participants who did not have type 2 diabetes. In addition, if we look at the effects on people who with an A1C below 7 and above 7 at baseline and look at the effects on eGFR slope, we again see very clear benefits, even for those people who had an A1C below 7 at baseline, additionally supporting the glucose-independent nature of these benefits. And when we look at the cardiovascular outcomes, we see very similar patterns with clear benefits again, especially for hospitalization of heart failure, even in people who had an A1C below 7 at baseline treated with canagliflozin compared to placebo. And when we look at safety outcomes, there was no clear evidence of any increase in risk, even in people with an A1C below 7. So this argues that the results of these trials and the effects of these drugs are not glucose dependent. And I think, again, that's supported further by the findings of other studies, particularly the DPP-4 inhibitors, where despite lowering glucose, these drugs did not protect the kidney nor the heart for that matter. The other question we've asked is whether these benefits differ by baseline EGFR levels as an interesting question. And here we look at the effects on a range of intermediate markers in people who had an EGFR below 45, shown in blue at baseline, between 45 and 60 in green, and between 60 and 90 in purple. And you can see in the top left that the glucose-lowering efficacy clearly attenuates with reducing kidney function, as we know. In those who had an EGFR below 45, there was only a 0.15% reduction in hemoglobin A1C, but the blood pressure effects were maintained, the body weight effects were maintained, and the albuminuria effects were maintained, again highlighting this dissociation between the effects on glucose and the other effects of canagliflozin in this population. When we look at the effects on the clinical outcomes, firstly the primary composite outcome, we can see quite consistent effects across different levels of kidney function, with separately statistically significantly clear benefits even in those people who had an EGFR below 45. And when we looked at the renal specific composite outcome, we found the same result, as we did when we looked at the hardest renal outcome, the composite of dialysis, kidney transplantation, or death due to kidney disease. When we look at the cardiovascular outcomes, we see a very similar pattern, even in those people who had an EGFR below 45, consistent effects of canagliflozin compared to placebo on MACE, and also on hospitalization for heart failure and cardiovascular death combined, or hospitalization for heart failure alone. So there's no suggestion on any of these clinical outcomes that the benefits of canagliflozin attenuate, at least down to an EGFR of 30. Is there an increase in the risk of serious or renal-related adverse events? The answer is no. Even in people with an EGFR below 45, the rate of these adverse outcomes was reduced with canagliflozin. And the one outcome for which there was an increased risk in people with an EGFR below 45 was volume depletion. So it does suggest that these patients may be somewhat more volume sensitive than people with preserved kidney function, but that they're still likely to get the renal and cardiovascular benefits and to get these safely overall. What about the effects on EGFR slope? And these figures just show you the patterns of EGFR change over time are identical at different baseline levels of kidney function. People who had an EGFR below 45 had a smaller acute reduction in EGFR, shown on the left-hand panel here, 2.5 odd compared to almost 4 in people with high levels of kidney function, but the long-term protective effects on the rate of loss of kidney function were more or less identical. So the last bit of data I'm going to show you just looks at people who had an EGFR at entry to the study below 30. And one of the questions we're asked is how could that happen? The entry criteria only allowed people with an EGFR above 30 to participate. And that's true, but the entry criteria related to people's screening visit, which was the visit at which they were assessed for eligibility. They were then they were asked to come back after the run-in period on an average 4 to 6 weeks later, and they had an additional blood test done, but they were randomized if they were eligible based on the screening list of what those randomization levels showed. And what that meant was that there was 174 patients, as shown in this slide, who by the time they'd gone from the screening to the randomization visit already had an EGFR which had fallen below 30 at that randomization visit. And this slide shows the distribution of those EGFR levels at entry to the study. Almost all of them were between 20 and 30 mils per minute, very low levels. But when we look at the effects on outcomes in this subgroup of participants, even in people who had an EGFR below 30 at randomization, we saw a 3% reduction in the level of albuminuria, a clear effect entirely consistent with the broader population. And we also showed a significant slowing in the rate of loss of kidney function, even in these people who had an average EGFR of 26 at the time that they were randomized, a 43% slower rate of loss of kidney function compared to people treated with placebo. And when we looked at the rate of heart outcomes with a small number of patients, there was very few events, but the effect is broadly consistent with those seen in the overall population. And lastly, when we looked at all patients whose EGFR fell below 30 at any time during the study, so this is not now a directly randomized comparison, and we're not necessarily comparing apples with apples because more people had loss of kidney function to this level in the placebo arm than the canagliflozin arm. Again, we see very similar patterns with lower rates of events in canagliflozin treated participants than those treated with placebo. So Credence clearly demonstrated that in people with diabetic kidney disease who are at high risk of both adverse kidney outcomes as well as cardiovascular outcomes, you could prevent one composite outcome for every 22 patients. You could prevent one person from having the outcome of end-stage kidney disease, doubling of creatinine, or renal death for every 28 patients you treat, and prevent one case of end-stage kidney disease for every 43 patients you treat for an average of 2.5 years. In addition, roughly 1 in 40 patients will be prevented from being hospitalized for heart failure or having major cardiovascular events. Clearly, these benefits are at least comparable and arguably greater than many of the other treatments we use routinely in this population. Subsequent to the trial, we've seen updates to renal guidelines and cardiovascular guidelines and diabetes guidelines around the world. The ADA within 6 weeks or so had updated their living guidelines to recommend SGLT2 inhibitors in people who had macroalbuminuria and EGFR in the range of the Credence population. The ESC has subsequently updated their guidelines. The ERA, EDTA guidelines have been updated, all now suggesting the use of SGLT2 inhibitors very early. And most recently, the KDIGO Global Renal Guideline, in their draft version, the full version to be released shortly, also recommend SGLT2 inhibitors as first-line therapy with metformin in all people with diabetes and kidney disease. The product information has been updated in the US now to reflect an additional indication for canagliflozin to prevent the renal outcome, the first drug of its kind to have this indication for almost 20 years. So we now have a drug available to us that we can use for our people with diabetic kidney disease who are at very high risk of adverse outcomes that will protect their heart, reduce the risk of MACE, reduce the risk of heart failure. It will protect the kidney and reduce the risk of kidney failure, as well as loss of kidney function. And it will also improve diabetes. But the truth is that it's a cardiorenal drug that happens to lower glucose rather than the other way around, in my mind, in terms of the magnitude of the benefits that we get. And so what I've tried to show you is that Credence has clearly demonstrated that canagliflozin protects kidney function in people with diabetic kidney disease, regardless of the level of acute EGFR decline that we see, regardless of the level of glycemic control, at least down to an EGFR of 30 and possibly below that to be defined by ongoing studies, and that it may protect against both the incidence and the severity of acute kidney injury. It also prevents heart failure and major cardiovascular events in diabetic kidney disease. This population is the highest of any in terms of their risk for this outcome. And again, it's regardless of glucose and EGFR. The mediators suggest some areas for future studies, but really the onus is now on all of us to use these drugs and make them available to the people who will benefit from them to help to reduce the risk and the burden of diabetic kidney disease and kidney failure, both in the Philippines and around the world. And to finish up, I'd just like to acknowledge all the participants in the study, and particularly here I'd like to pay tribute to acknowledge the many investigators from the Philippines who were important partners in generating this data, and they're listed on the right-hand side. And I'll pause there and thank you very much for your attention.
Thank you, Dr. Perkovich, for that extensive discussion on the new drugs or the new innovative drugs that we use among diabetic patients. Now with not only for the use among diabetic patients, but we've seen both the cardioprotective and renoprotective properties of this drug, both for decreasing in the incidence of heart failure, and you know that the renoprotective effect would be on the decrease in the rate of decline of eGFR before going to end-stage kidney disease, and also its potential value in decreasing mortality among diabetic patients. And also we've seen that the drug has cardiovascular and renal effects independent of blood sugar control, and at the same time the effect on the GFR. So with this, we're now opening our question and answer, but probably we could entertain two of our leaders in the field of nephrology who might give us some insights, comments, or even questions related to our topic this evening. May I call Dr. Lynn Gomez, and then followed by Dr. Elizabeth Morgan. Dr. Lynn Gomez.
Yes, hi Benji. Good evening, Professor Blado. This is Lynn Gomez. I work with you at the Credence Trial, so I'm glad that you are able to speak with us, even if it's just remotely. And I'm very excited about this new drug that has really revolutionized how we should treat the diabetic patients and probably even the non-diabetic patient. It's been 20 years, you said, since the RAS blockers have been available to us, but we see that the numbers needed to treat is much, much more to get the advantage compared to what you presented in the Credence. And of course, the problem that we also have, and mostly the other practitioners with the RAS blocker, is that GFR decline. And now we also see a GFR decline with the SGLT2, although of course the mechanism would be very different. And in fact, now I think in the latest era at the virtual convention, they showed a study in particular wherein they really look at that. They call it now the eGFR drip and characterize it into what you're saying as far as the Credence. 3 different kinds of drop, and that is less than 10% and more than 10% and no change. And it seems now that those who drop their GFR some more, according to their multivariate analysis, is showing that these are the ones who have used diuretics, and these are the ones who have also a very advanced kidney problem when you look at their KDIGO classification. So would you also think that this is true for all the other SGLT2s, particularly for CANA, as far as a type of warning regarding the use of diuretics, also more than 30% drop in GFR? Or do we say that there is really no worry, because ultimately you have shown in the Credence that it really has improved afterwards? And then of course my next other comment is as far as the mechanism. Would you say that the GLP-1 agonists will be good complementary drugs to the SGLT2, specifically in those with very low GFR or those on dialysis who needs insulin treatment? Or is it a contest now between the SGLT2 and the GLP-1? So those are my reaction and maybe questions, and maybe later on again I can ask some more if you have more time. Thank you.
Thank you very much, Lynn, and it's great to speak to you again, and always absolute pleasure to work with you. Thanks for your comments and the challenging questions. I think just to pick out a few points, does the acute effect matter if it's above 30%? We don't know for sure. What I can say is that a reduction in EGFR of about 30% or more only occurred in about 1 to 2% of people in Credence. So it was very uncommon. In fact, we'd hoped to assess whether the benefits were still present even in people who had a 30% or greater reduction, and there was too few of them for us to be able to analyze. So what that tells us is it's rare. Even in our population, where most of them were treated, the majority were treated with diuretics of some form. What we did notice was that there was a small number of people who had profound reductions in blood pressure or EGFR or both. And in those patients, often they were treated with multiple blood pressure lowering agents. And in fact, by reducing some of the other treatments, whether they're diuretics or other agents like calcium channel blockers, etc., that acute effect the acute reduction came back towards baseline, and the SGLT2 inhibitors could be continued. So I don't think that's going to be, in the long term, a very common problem with us, for us. In terms of your question about GLP-1 receptor agonists, I think there's some promising data for that class of agents. I don't think there's any sort of competition, and I suspect in the long term we may end up using these agents together in a large proportion of our patients as we start to get more and more data suggesting that the benefits are complementary. But there may well be some differences. The data that we have for GLP-1 receptor agonists suggests that they may be particularly beneficial for the kidney in people who've already got reduced kidney function, which remains unexplained at this stage, and it could still be a chance finding, but it suggests that the mechanism by which those drugs act might be somewhat different to the SGLT2 inhibitors, suggesting that they could be complementary. So I hope in the longer term we end up using them together.
Thank you. Thank you. Thank you very much.
Thanks, Lynn. So Dr. Balmaris, I see there's a lot of questions in the Q&A.
Yes.
Would you like me to try and address some of those?
Yeah. Or before addressing those questions, may I call Dr. Montemayor to give her comments also, or some views regarding the topic this evening?
Thank you.
Dr. Montemayor. Okay, while waiting for the comments of Dr. Montemayor, we can start reading the questions. First question is there any difference in patient population of Credence and Canvas that puts patient on Canvas to be on higher risk of amputation, such that those patients with history of prior amputation, peripheral vascular disease, neuropathy, and diabetic foot ulcers are all factors that may put patients at an increased risk?
Yeah, it's a good question, and we've looked at this quite extensively actually, and in fact the patients in Credence were at higher risk of peripheral vascular disease and amputation by virtue of the fact that they had kidney disease, which is a strong risk factor for diabetic feet. But these factors did not influence in either Canvas or Credence the effects of the drug on the outcome, or in the case of Credence, the lack of effect. We've looked at this in many, many different ways to try and understand whether there was something special about Canvas that made it different. The patient population was comparable, and when we look at the patient subgroups that were the same, we see discrepant effects. The treatment was the same, the outcome was the same. It's increasingly likely that what we may have seen was an overestimate of any effect on amputation in Canvas as a chance result. And then when we tested that prospectively in the subsequent randomized controlled trial, which was Credence, we didn't find that effect. So I think that it's not related to baseline characteristics or the treatment. It's likely related to the actual, just a chance finding in that trial. And the second question there, I think, which is related, asks about tenderness or sores or ulcers in the legs or feet in Credence, but that did not lead to amputation. We didn't see any increase in the risk of those outcomes as reported as serious adverse events in the trial.
Then next we have, can SGLT2 inhibitors be used as an adjunct treatment for patients with albuminuria and CKD, even if patient has no diabetes?
Yeah, that's a really interesting question and very topical at the moment. The data that we've got from Credence suggests that certainly in people with well-controlled diabetes, the benefits are just as large. And that suggests that they might also be there even in people who don't have diabetes. That hasn't been tested clearly in Credence. There was an interesting study published in Lancet Diabetes and Endocrinology a couple of weeks ago, the Diamond study, which looked at the effects of dapagliflozin in proteinuric non-diabetic chronic kidney disease and did not show any reduction in albuminuria, which is interesting. But of course, we'll learn more when the DAPA-CKD trial is reported at the American Society of Nephrology meeting this year. In that trial, they included people with non-diabetic kidney disease as well as people with diabetic kidney disease, and the trial was stopped early because of overwhelming benefit, according to the leaders of that study. So we will hopefully in November see whether the effects of dapagliflozin as the SGLT2 inhibitor used in that case are similar, comparable, larger, smaller in people without diabetes as well as those with diabetes.
Okay, so next question. With regards to its effect on heart failure and cardiovascular outcomes, were the underlying cardiac concomitant medications maximized or homogenized in the baseline enrollment?
Yeah. So we worked very hard to try and make sure that the participants in the study were treated as well as possible. We asked the investigators to follow all the relevant guidelines for the management, not only of their diabetes, but also of their kidney disease and also of their cardiovascular risk. And we provided specific guidance for some of the factors that they should look at around blood pressure, around lipid lowering, and around antiplatelet agents, for example. And what we saw was pretty good use of all of those agents, as we, by definition, almost 100% of the participants were treated with RAS blockers. All of them were on blood pressure lowering of various combinations. The average blood pressure at baseline was 139 millimeters of mercury systolic, and that was despite an average of 3 blood pressure lowering medications. So I think it also reflects the fact that these people have blood pressure that's generally quite difficult to control. The average lipids were reasonably well controlled, and the majority of patients were on statins. In addition, we found no difference in the effect on any outcomes in people who were or were not receiving those drugs. So I think what we can say with some comfort is that the benefits for the cardiovascular outcomes as well as the renal outcomes were present on top of best available therapy.
Thank you. Next question has already been answered. Can we use canagliflozin in non-diabetic kidney disease? So the next question is, are the adverse effects similar to those with eGFR less than 30 mils per minute?
So it's a good question, and certainly in the analysis that we've done of our 174 patients, we saw similar adverse effects, but it should be noted that the number of people with that level of kidney function in Credence was relatively small compared to the overall population. We didn't see any signal for an increase in adverse events of any type in that subpopulation, but we will learn more with the ongoing trials. The DAPA-CKD trial is including people with an eGFR down to 25, so it will extend that lower limit a bit. And the EMPA-Kidney trial, which is still recruiting, I believe, and currently underway, will include people down to an eGFR of 20 mils per minute. So we will get more information, but in either the randomized comparison at baseline or the data that looked at just people who were achieved an eGFR below 30 during follow-up, we found no difference in the rates of adverse events.
Okay, so the next two questions are similar. Do you think the benefit of SGLT2 inhibitors is a class effect? And can the renoprotective and cardiovascular benefits seen in patients on canagliflozin be considered a class effect among all SGLT2 inhibitors?
Yeah, look, it's an interesting question, and the only way to answer it with certainty would be to do head-to-head trials of these agents, which I don't think will ever be done. So all we can do at the end of the day is some sort of indirect comparisons. and it depends on your philosophy in some ways. Some people believe that all these drugs should be considered the same unless they're shown to be different. Others believe that they're all, they each need benefits. If we look across the class, we see really quite consistent effects overall for the drugs on the kidney. We see broadly consistent effects on cardiovascular outcomes. There's the recent data from the Virtus study raises questions about whether ertugliflozin may be a little less potent at protecting renal or cardiovascular systems in people with diabetes, but we need to be a little bit careful in interpreting that. I think the best available data is that they are likely consistent, but I think equally we just need to follow the data. What we do know is canagliflozin clearly protects both the kidney and the heart in this population. There's similar but slightly different data supporting benefits of other agents in the class in slightly different populations, and I think we should follow those data when we use these.
Okay. Can SGLT2 inhibitors be given to ESRD patients?
Yeah, I'm not aware of any studies to date that have looked at that question. It's interesting to think about, and when we started Credence, we excluded people with an EGFR below 30 at baseline because the data clearly showed at that stage that the glucose lowering effect was reduced once people lost significant kidney function. So we wouldn't expect clearly to see any glucose lowering effect in people with end-stage kidney disease, but the subsequent dissociation we've seen between the glucose lowering effects and these other effects suggest the possibility that the drugs might have benefits. And of course, people with end-stage kidney disease have the highest risk of all for heart failure. So I think it's an open question, an interesting one for future study, particularly to ask whether there may be benefits on cardiovascular outcomes in people who've got who have end-stage kidney disease on dialysis.
Okay, still have a couple of questions here. Patients with eGFR less than 30 mils per minute have lost a significant number of functioning nephrons. What is the mechanism for the renal benefit of canagliflozin seen in this population?
Well, that I think relates to the
previous,
the question about the renal benefits overall. We still don't know what the mechanism of those benefits is, and I think we still have a lot to learn. It may, for example, be related to effects on the tubule and particularly tubular energetics. There's a whole range of other hypotheses as to how these agents may have an impact on the kidney, even if they've got relatively reduced kidney function. I don't know the answer to that question. I think we have to watch this space.
Okay, thank you. So next question is, what protects against hypoglycemia in non-diabetic patients?
Yeah. So in the nice thing about these drugs is that there's a natural brake on their glucose lowering effect. What they do is they lower the renal threshold for glucose loss, so that people start to lose glucose in the urine at a much lower level than they normally would. But the rate of glucose loss is still dependent on the concentration of glucose in the blood, which therefore drives the glucose concentration of the tubular filtrate. So in people with normal glucose, they lose much less, they filter much less glucose, and they tend to have much less glucose lowering or glucose loss as a result, which also in turn allows their body's homeostatic mechanisms to protect them against hypoglycemia. It's one of the nice things about this class of agents is a natural intrinsic brake.
Okay. So next question is, how big a drop in eGFR will make you consider withdrawing canagliflozin?
Yeah, so what I would do in these patients is I would treat the patient. What we often see is a bit big to improve a bit on its own if we just wait for a few more weeks. What I typically would say is if the acute reduction is more than 30%, I would look at their other treatments. If they're on diabetics or if they're on diuretics or blood pressure lowering agents, I would consider lowering the dose of those drugs first and seeing if that stabilizes kidney function. But if there's a persistent reduction in kidney function above 30%, then in those patients, I would probably at this stage elect to stop the drug until we've got more information. But that really happens very rarely.
Okay, so I think the subsequent questions were answered earlier regarding the difference among SGLT2 inhibitors for renal protection. Okay. Okay, so would you give canagliflozin patients with GFR less than 30 ml per minute to prevent hospitalization for heart failure?
Yeah, I think it's an interesting question. I think the data I've shown you from Credence suggests that that may well be a very important strategy actually for these people who are at extremely high risk of heart failure. I think we do need more data before using that routinely, before starting with canagliflozin routinely in these patients. But I think the data that I've shown you gives us additional comfort that it's absolutely fine to continue the drug in people whose eGFR falls below 30. And in fact, it's more than fine. It's really quite beneficial. So we should continue to do.
Okay. So will there be no concern on chronic exposure of distal tubules to high glucose states?
Short answer, no. We now have data from studies like Canvas where patients were treated for up to 8 years with SGLT2 inhibitors, and we saw ongoing kidney protection with no evidence of any sort of kidney toxicity, tubular or otherwise. So I'm very comfortable that there's no concerns there.
Now, how about the rare side effect of acute pancreatitis among those with diabetic ketoacidosis?
Yeah, so we now have a number of trials of this class of agents, and I think it's pretty clear that they do not increase the risk of acute pancreatitis. They do increase the risk of diabetic ketoacidosis, particularly in people with long-standing diabetes who are receiving insulin. So that's something that it's important to be aware of and to counsel our patients about.
Okay. Question on safety of SGLT2 inhibitors to kidney transplant patients. Does it have a drug-to-drug interaction?
Yeah, I don't think there are any important drug-drug interactions, and it's a really important question. Clearly, kidney transplants are a population in whom we particularly want to protect kidney function, and there are studies currently underway. I think the concern in those patients is about the risk of infection, where if they were to get an infection, for example, a balanitis or a vulvovaginitis, which we know are increased with these agents, could they be more severe in kidney transplant patients, and might that be a concern? I think there are studies currently underway that will help us understand the answer to those questions, and I'd recommend waiting until those results are available before using these drugs routinely in kidney transplant patients.
You can see here that there's a lot of things that we have to learn more on the use of these SGLT2 inhibitors. Exactly. We have been bombarded with a lot of questions, and I think this increases our learning curve about using the drug. So do you suggest stopping SGLT2 inhibitors in DKD patients admitted for acute illness?
Yeah. So I would suggest firstly checking the other treatments the patient's receiving, seeing whether it's possible to stop diuretics or blood pressure lowering agents, make sure that they're not volume depleted, or make sure that they are keeping their fluids up as a first step. And by paying attention to those factors, we can usually control the kidney function and keep the patient on an SGLT2 inhibitor rather than needing to stop.
Okay, I think this is the last question. Should we give it as part of the standard of care among non-diabetic patients?
I think in non-diabetic patients at this stage, it's too soon. I think we need more data in non-diabetic patients so that we not only understand whether the benefits are the same, but also understand whether there may be some other unexpected risks in that population. I think we'll learn a lot in the next few months when DAPA-CKD reports, and it could be I'm not involved in that study, so I have no idea what the results show beyond what's been publicly released, but I think that will be the key step forward in terms of non-diabetic kidney disease at this stage.
Okay, I know that there's still a lot of things that we have to learn from the using this drug and trying to gain more experience and be able to contribute to more data that we can medications. Final comment. Okay, so with this, Dr. Perkovich, we would like to thank you for being our speaker this evening, and really learned a lot. And it's really a great pleasure for us nephrologists in the Philippines to listen to this new drug and its beneficial effect among our diabetic kidney disease. So again, thank you very much.
Thank you. Thank you very much.
Okay. So as an announcement for our annual business meeting and election of National and Chapter Board of Trustees, the meeting will be on July 12, 2020. The election will start at 8:30 in the morning up to 5 p.m. And our usual business meeting will start at 9 a.m. to 11 a.m. Please confirm your participation on or before July 6. And ensure that your email address is correct and updated at the PSN website. So with this, I'd like to call Dr. Villanueva for any other announcements. Russell?
I would like to thank everyone for attending. Next week's webinar would be on kidney transplantation during the time of COVID-19 with our guest, Dr. Beatriz Concepcion of Vanderbilt University as our lecturer. So thank you everyone for attending, and we hope to see you in our next webinar.